Test 1 2 3. Testing 3 2 1.
Yes, sir, I can. Let's do a live test out to YouTube. Good to go.
Thank you. I'd like to welcome everybody to the virtual Board of Managers Quality Committee meeting at 1500 hours or 3 p.m. Thursday, May 6, 2021. And first thing I have is citizens wishing to address the committee. Do we have any, Sean?
No, sir, there are no citizens.
Okay, then the next is consider matters requiring committee action. The first is approval minutes of March 4, 2021. And I'd entertain a motion for approval.
Zim moves to approve.
Is there a second?
Steve seconds.
All right, discussion. All in favor, please say aye.
Aye.
Opposed, say no. Motion passes. Next is approval of Tarrant County Hospital District policies and/or plans. First up is LS 200, Interim Life Safety Measures Assessment Tool. Adam, where's Adam?
I'm here. Hello, everyone. Good afternoon. How's everyone today?
All right.
So I am here to present an update for the LS200 Interim Life Safety Policies. This policy, of course, is for interim life safety when there are construction projects or impediments in the hallways or somewhere that affects life safety and means of egress. The policy itself is very short. It's the procedures that had the bulk of the changes. Most of that was to bring our policy in regulatory compliance with 4 forms regarding fire life safety, inner life safety checks, fire watches, etc. The rest of that was all grammatical and or name changes within the procedures, departmental name changes. And that is the extent of this.
All righty. With that, I'd entertain a motion to approve, please.
Move approval.
There's DT.
Second, Steve.
Second. Discussion. I want to say one thing, and this is going to be, I guess, just how our policies are written and promoted. I'm not a big fan of best practice standards. I'm more of a fan of evidence-based standards. And what I'd like to do is just whichever one you want to choose, let's keep it standard across all of our policies and procedures. And that's my only thought for the discussion. So all in favor, please say aye.
Aye. Aye.
Those opposed say no. Not hearing any no's, motion passes. Next one I have is Infection Prevention and Control Program Authority and Approval Statement. Rob Stevenson.
Yeah. Thank you, Dr. Weber. Thank you for the opportunity to present this policy to the committee today. So this actually was substantially changed. Basically, what we did was combine IC1 and IC100 into a single policy. There was, since they were modified frequently and at different times of the year or different times in the cycle, there was always a potential for conflict between the two, and they seemed quite redundant. So we have retired IC100, and IC1 will now suffice for both. The purpose of this is to establish that the governing body of this hospital, which is this group, or the board, the full board really, is responsible for overseeing our infection prevention and control program. And through the MEC, the Medical Executive Committee delegates that authority to the Medical Director of Infection Control and Prevention, which is currently Dr. Saqib Hassan. It then outlines all of the aspects of conducting an infection control plan for JPS, our program for JPS. So that is this policy. And as far as the content, rolled together, all of this content was previously in those 2 previous policies, but just now pulled together into a single policy.
All right. Anybody have any comments or questions for Rob? Hearing none, entertain a motion to approve.
Move approval.
Zim second.
Jim second. Any further discussion? All in favor, please say aye.
Aye.
Those opposed say no. Motion passes. Number 3 is infection prevention for year 2021 annual plan. Rob, you're up.
Yeah. So this is an annual requirement of annual regulatory requirement for our organization to have an annual plan with goals and to assess the results of last year's plan. Obviously, last year's plan was fairly disrupted by COVID. So if you go through that aspect of the plan, you will see that there were a bunch of things there were quite a few things that we did meet, but then there were a number of aspects of the plan which were either not met or partially met. A lot of that was due to the disruption that we have all seen because of the global pandemic. As far as the goals for next year, the other thing that's in here is our infection prevention risk assessment, which you'll see on the back pages, and then or the middle pages, and then finally pages 32 through 32. Starting with pages 32, you'll see our goals for next year, which are start with the SARS-CoV-2 COVID-19, which is implementation of a COVID-19 procedure with greater than 90% compliance with isolation rounds and PPE utilization in fiscal year 2021 is our specific goal for that. Then we have goals around reduction of central line associated bloodstream infections, surgical site infections, and then improved compliance with high level disinfection and sterile processing. So I would love to put this forward to you for your consideration and approval.
Dr. Stevenson, I have a question.
Yes, sir.
On that chart for risk assessment, you have
Yes.
yellow and red. Could you refresh our memory what they are?
Yeah, so yellow would be
What pages are you looking at?
It's from 33, I think, 34 to
yeah.
to 37.
So low risk things are not colored. Or where we believe our risk based on the risk assessment is relatively low. Yellow would be moderate risk, and red would be high risk for us. So the areas of highest focus are the areas that are in red.
When you mean high risk for us not achieving, or highest risk that we need to work on, or
highest, I would say highest overall regulatory risk and risk to our patients. So the areas that require the most focus.
Yes, sir.
Not the things that are necessarily the most non-compliant, just the things that require the most attention. So this is a risk assessment for the organization. It's not a description of current state. See what I'm saying?
Okay, so the rest non-color is more like a
more routine matters.
So this is the traffic light then. That's kind of concept.
That is precisely correct.
Yes, sir.
It was a lot of heavy reading.
Indeed.
Anybody else have any discussion, thoughts about the plan, etc.? Hearing none, entertain a motion to approve.
Dorothy, move approval.
There she is.
Zim, second.
Discussion, anybody? All in favor, please say aye.
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 Those opposed say no. Motion passes. We're now performance improvement reports updates not requiring committee action. First is PSI 90 and the quality scorecard. Rob, you're up again.
Yes, thank you. May I have the slides, please, Sean? Oh, sorry, Jeffrey. Thank you. Can we go to presentation mode? Great. Great, thank you. Next slide, please. Great, next slide, please. So before I get into the meat of my usual report on PSI 90, I wanted to bring before the Quality Committee our recent achievement in our Leapfrog safety grade. So after, with some really phenomenal effort across the organization, we have achieved a grade of B for the spring 2021 grading period. So the Leapfrog, as you may recall, is a grade, a safety grade that is followed by a lot of watchers in the healthcare industry. That grades hospitals based on a variety of aspects of quality that go on there, including their safety practices, safety culture, and then results like patient experience and outcome measures, for example, harm events like the PSIs that we're going to talk about in a moment, as well as hospital-acquired infections and other hospital-acquired conditions like fall with injury and that sort of thing. So we have now achieved a grade of B. My informal review of the other city county hospitals in the country show that that it was an informal survey, so I'll admit that. But the only other city county hospital in the United States that I could find that had a B was San Antonio, which is a little bit of a different facility than ours, but the places like Grady and Bellevue and Cook County and Boston City and all those places, LA County, San Francisco General, and then of course our neighbors in Parkland, and then the hospitals in Houston, Ben Taub, and LBJ. None of them had a B, so that's so we got our head above the crowd a little bit here, so we should be very proud of that. I still think that there is room for improvement. I think that I would hope and expect that we can improve this further. And we're certainly working very, very hard on that right now. If we can go to the next slide, please, so we can look at our history.
Can I just let everyone know on this board that in order to get a Leapfrog B grade is really a phenomenal effort. And I want to commend Dr. Stevenson and his entire group for doing an outstanding job to achieve this for our institution. It is a really big deal, and it is really hard to get. So I congratulate Dr. Stevenson and that entire group for a well done effort.
Do you know what changed in 2018 that set us back so much that it took 3 years to get back?
Yeah, there were really several things. I think that we had to improve things. I think the reason that we did fairly well in spring and fall of 18 was that we actually had some pretty good results at that point in time in terms of central line infections and catheter-based urinary tract infections. There may have been some. Well, I probably won't. That may be a little bit too speculative for this forum, but I think that there was some fallout. And if you remember as well, during 18, that was a time in which those measures, CAUTI and CLABSI, were actually the AIP goals that you all had put forward for us as an organization for quality as our quality pillar goal back then. So, there was attention put on it. We improved those things. And then, as I think I've discussed with you in previous, meetings some time ago, one of the problems that we had in the past was that we'd put attention on something, we'd improve it, and then our attention would move away, and then it would get worse again. And so what we had to do over the last couple of years was make sure that we had our attention on everything that we needed to have our attention on. So not just PSI 90, but also urinary tract infections, central line infections, and falls, pressure ulcers, all these things that are important for making sure that our patients are receiving safe and effective health care at JPS. So I think the big pivot was really to make sure that we had our attention on everything, and it just takes time to move Leapfrog grade because a lot of the measures, as I've mentioned to you before, are a bit lagging. So even this data, spring 2021, only includes, for example, I think 3 months of a time period where we actually were doing really well in PSI 90, for example. So we've now been doing well in PSI 90 for a couple of years. So it's just going to take time for that effort to be properly reflected in our grades. So it's going to take a little bit more time to see further improvement, but But it's really, it takes because there is a lagging aspect to this. You've really got to put in a tremendous amount of effort over time to really move this in a sustained way.
That makes a lot of sense. Build the right foundation and just build on it.
Yep.
Thank you.
Yep, that's what we've been trying to do. All right, next slide, please. So I want to bring you back to the end of our first quarter of fiscal year 2021 with what was going on with PSI 90, because I think that it will help understand where, what has gone on as a consequence of the big surge of COVID-19 that we experienced in January, and then the disruptions from Snowmageddon as well. So there was a lot of so nationally, and certainly in our more local area, there was a lot of disruption that happened in that first quarter. But if you go back to the end of the first quarter, we were doing really, really well. In fact, we were ahead of stretch. Next slide, please.
Rob, before you get on.
Yes, sir.
Did I hear you correct? Snowmageddon?
Snowmageddon, yes.
Okay. Is that now a recognized word by?
I don't know. We've used it a lot around here. It certainly felt like that.
All right.
So we had a great first quarter, but then, things really went the wrong direction in the second quarter here. These numbers were driven tremendously by pressure ulcers. Turns out COVID patients have vascular disorders to their skin that make them even more prone to pressure ulcers. And on top of that, when patients are prone, and this is published data, roughly 35 to 40% of patients who have to be prone for ventilation on a ventilator, which is very common for COVID patients, will get pressure ulceration on their face and other parts of their body, because we're not really designed to lay on our tummies for long periods of time, especially when we can't be moved. Because patients who are that sick on ventilators tend not to do very well when they're moved in any way. And I know Dr. Miller, who does a lot of critical care, can speak to that in great detail if anyone has any questions about that. But in any case, this was really a national phenomenon and definitely hit Texas very, very hard. And folks' quality measures, safety and quality measures across the board, across the United States, were very disrupted in that second quarter of fiscal year 2021, so that January, February, March. So much so that barely 2 weeks into April, the federal government was already letting all the hospitals know that they weren't going to be looking at measures for this particular quarter for the purposes of value-based purchasing or the HAC reduction program, the hospital acquired condition reduction program. So this is really a manifestation of a stressed healthcare system, and is certainly by no means unique to JPS. And to that point, I have preliminary data from April, which indicates that April itself may be the single best month that we have ever had in PSI 90 since we began the work on this. Now back during at the beginning of fiscal year 2019. So we seem to have snapped back very rapidly from this period of disruption to performance that is much more akin to what we have been seeing and doing here for the last couple of years. So I think that this, despite all that, despite saying all that, none of us were very happy with these results that we were seeing during that quarter. So we actually launched a lot of initiatives around getting our pressure ulcer reduction back in line and working on other aspects of one of the things that Dr. Miller and I are working a lot right now is the issue of frailty and surgery, because we've had a couple of patients who have suffered postoperative sepsis. And we want to make sure that we are really getting patients ready for surgery, not just in the typical ways one does, which is getting their diabetes better, getting their blood pressure better, making sure their heart's okay, but actually looking at their overall physical capability of handling a major operation. And so through our surgery optimization program, we are now assessing frailty in a much more structured way and beginning the process of looking at opportunities for really doing what's called prehabilitation or prehab with our therapy services group to see if we can actually get folks physically ready for what is a physically demanding thing, which is having a major operation. So I don't know if Dr. Miller wants to make a comment about that. He's actually one of the world's experts in frailty and surgery, but do you have any comments, Dr. Miller?
Well, let me just give you a few comments first about COVID. One, we're starting to see the repercussions of this disease that may be for a prolonged period of time. I'm just taking care of a fireman right now that had COVID in November and December and was in a motorcycle accident, and we scanned his chest, and he had significant residual disease in the unaffected lung from COVID. And he's been saying he's been fatigued and a little short of breath. So we will probably see a subgroup of patients that have had COVID that do have long-term effects of this. So I've been on, talking to people and person that, gives me my haircut said I'm not getting the vaccine because I've already got COVID, or if I get it, it's no big deal. I'm healthy. But really, the vaccine is so important to prevent some of the repercussions that people were going to be getting in the future. So I reviewed an amazing PowerPoint presentation on this entity of these skin necrosis and pressure ulcers with COVID patients. And it's not just the pressure, but it's the thrombotic events that occur, basically the clotting that causes that skin to be more predisposed to these ulcerations. So it's part of the disease process, as Rob had mentioned. As far as frailty goes, you all know that the population of the United States is growing in the elderly group over 65. It's going to encompass 25% of the population within the next few years. And these are the folks that we're going to be taking care of. 50% of operations in the United States are done on people over the age of 65. And we really have to be able to delve deeply into their pre-existing disease and their ability to tolerate a big hit on their physiologic reserve. And so we are going to focus a lot of our quality endeavors over the next year on trying to identify people that do have frailty, and not every person necessarily should undergo an operation just because there's something to fix. And so we really need to think about every single patient that we're operating on, and as Rob said, determining their ability to tolerate that by assessing their physiologic function, their cognitive function, and whether or not they have frailty or not. So more to come on that. I'm happy to answer any questions regarding this endeavor, but it is a big thing that is across the entire United States right now.
Okay. Next slide, please.
Before you go on, Rob,
Yeah.
Rick, weren't you at one point talking about a frailty index or something special in studying?
Yeah, Linda Fried at Johns Hopkins was the first to identify the frailty subpopulation and develop the Frailty Index. It has been altered multiple times, adding additional risk factors, including the size of your psoas muscles, your hemoglobin A1C, doing a simple test that you can do in the office to determine whether or not you're going to be able to tolerate a stressor and deplete your physiologic reserve or not. And so we're still developing this, Chuck, across the country on what the best frailty score is and what the Frailty Index looks like. There's many really good ones out there. We published one in the American College of Surgeons. You can go online there and look at the practice management guideline on that. But we are constantly adjusting this Frailty Index, and I believe within the next year or two, the college will have a really good tool that will be way better than the ACS risk, stratification and risk factors for surgery. So I'm pretty excited that we're headed in that direction.
Well, great. Would you be kind enough to give us an update as you get more of this data and develop the index, if you would?
Yes, sir. Happy to
It might
do
even
that.
be good. It might even be a good one for the whole board to hear once you've got more data and developing things.
I'm happy to do that.
All righty, Rob, you're back.
Yep. So as you can see, after those 3 rough months, our overall score for the year right now is 1.34. So we went from 0.77 in stretch territory, and after these 3 tough months of dealing with the national disruptions associated with our huge spike in the pandemic and other events like Snowmageddon, we're now at 1.34. This most recent month has us back down closer to 1.1 because the month was so good. But this last quarter was pretty tough. And as you can see, things were hugely driven by our pressure ulcers, driven by our post-op sepsis, which has been a big factor this year, which is why there's so much interest in this frailty issue. The one thing I should point out, which is really actually pretty interesting and pretty wonderful actually, is that in that leapfrog score that came out, when we our score on DVT-PE at that time was, I think, about 3.8, which was above the national average. These scores of 1.44 and 1.58 for DVT-PE are actually among the best in the United States at this point in time. So all that good work. So even though we've seen some disruption around pressure ulcers and things like that, all that work that we've described previously regarding DVT and PE actually puts us that number there. Actually, this number here would make us, if that was our score for leapfrog, would actually make us the best in the country, and this would make us very, very close to the best in the country. The best is right around 1.55 for that particular measure. So that is pretty wonderful work that's been done by so many individuals across this organization, particularly in using risk calculators for choosing appropriate DVT prophylaxis here. There's one other big one too, which is that our trauma program, which is particularly where our patients are particularly high risk for DVT and PE, are tremendously aggressive in prophylaxing our patients who have injury. And so, a population where a lot of folks are kind of reticent about starting anticoagulation too soon. Here at JPS, we follow the evidence-based guidelines, to your point, Dr. Weber, and know that we can start a brain-injured patient with a stable brain bleed after 24 hours on anticoagulation, or even people with solid organ injuries like liver injuries and things like that, that we can start them once we know for sure that they're stable. And so we've been able to very broadly and very reliably start prophylaxis in what is actually a very high-risk group and achieve what are now either nearly or actually nationally leading results for that measure.
I think that's great.
So that has been a true step forward for JPS. So next slide, please. So here you can see the different rates of the different things. I think we can move on from this slide. For our infections, so far we're actually ahead of last year's performance in colon surgical site infection. Actually getting very close to best in country for that, which is great. Our hysterectomies are going well for the year so far. Arthroplasties are going well for the year so far. The areas of challenge have been around, the central line infections and the urinary tract infections. We are a little bit worse than last year's performance so far in the urinary tract infections, although we have been able to bend that curve back down in April, which is great. Similarly, central line infections, which were really very much impacted by COVID care and a lot of the situations that have been seen across the country with regards to central line infections, we were impacted as well. And this has also been bending back down very rapidly in April. So I'm pleased to report that. and we're ahead of last year's performance in Clostridium difficile infections. We remain at a very, very strong level of performance in bloodstream infections associated with MRSA. So that's also been very strong performance for us. And that's been maintaining now for quite a few years. Next slide. All right. Does anyone have any questions or comments?
I have one comment, Rob. Isn't this week Nurses Week?
It is, in fact, Nurses Week.
Well, I would like to say congratulations, especially to our two nursing leaders. These results that you have given us, that's in the face of a lot of traveling nurses that have not had a whole lot of experience with COVID type people. And hats off to the nurses, not only because of the week, but because of the way they've taken care of our patients.
Thank you, Dr. Weber.
Want to say thank you.
Thank you. And I will share, especially with the nursing leadership team, your kind words. We appreciate it.
All righty.
Well, I think the thing that's really the most cool, in terms of this data, and just as a testament to how great our nurses are here at JPS, is how quickly everything snapped right back into line. So the whole country got stressed and challenged and all that sort of stuff, but here at JPS, literally, they've turned it on a dime, and everything is the work is back at the highest levels of quality, and it's just amazing just how well they have the degree of resilience that they've exhibited. And obviously it was interesting. I was listening to an interview with the head of the DFW Hospital Council that Dina actually shared with me earlier today, which was a really good interview if you find it on the internet. But in any case, one of the things he said is the best way to celebrate Nurses Week is for those who haven't gotten vaccinated to get vaccinated, because if you don't get vaccinated, you make the lives of our nurses really, really hard. And so go out there, get vaccinated, celebrate Nurses Week, and take care of our nurses. So I think that is probably the greatest way to celebrate our nurses and to help them and to make their lives better. So
excellent.
Can we call this the effect of Webergeddon?
No. Windgeddon sounds a lot better. I like that. Windgeddon. Okay. Any further discussion for Rob or Rick on this one? All righty. Patient experience, Laura Burnside.
Hello. Thank you for having me here this afternoon. I appreciate it very much. I cannot say enough as well about our nursing team and our clinicians as a whole and the entire hospital. I actually was a patient in-house for about a week, and I was absolutely blown away by the care that was given. And, interestingly, last year when I had a hospital stay, I was out of town and was not here. And when I asked my family what the difference was between this stay and the one last year, their comment was really incredible, because I think it was so telling of JPS as a whole. And that was, at both places, I received great clinical care. The difference at JPS was that it was delivered with care. And at the end of the day, when we think about the work that we do for our community and the care that we give to those that come through our doors, I don't think any of us take that lightly and consider it a complete privilege every single day. And so on behalf of myself and my entire team, I also thank our nurses and all of our clinicians, and Happy Nurses Week to all of you who serve tirelessly every single day to do everything that you do for our community. It's remarkable. With that, we can move into, I just have a short report this month on our organizational goals. So if you would advance to the next slide for me, please. We're currently meeting 4 domains or dimensions out of our HCAP survey, And just as a reminder, as we achieve the 75th percentile in these domains or dimensions, that is actually an indication that we are performing in the top of the country. And so to reach 4 of those is really remarkable. I do want to draw attention, as I have the last few months, to the care transitions dimension or domain. And as we started this year, just as a reminder, we were at the 15th percentile, meaning 85% of hospitals were outperforming us in that dimension or domain. And we are currently, as of our current quarter, achieving the 60th percentile. And so that is just a tremendous tribute to the work that's being done by our Care Transitions Committee, which is a multidisciplinary committee that has formed together in order to make sure that when our patients go home, they are well cared for, they understand what their care plan is, they know and agree to what's happening next in their plan, and they can actually do it as well as they can in partnership with us when they go home. So we will continue to work on that, as that's such a huge component for us of making sure that when we discharge patients from the hospital, they actually can participate in their next level of care. But as far as achieving 75th percentile, which is our goal, again, that indicates that we're at the top of the country. We're achieving that in overall rating, which is a compilation of just the overall stay, our communications with our physicians, which encompasses 3 different questions, one on courtesy and respect of our physicians, one on how well the physician listens and how often that happens, and the other on how often and well the physician explains things to the patients in a way they can understand, their discharge information, and if they were given that, and then the communication that we've done on the medications that the patient is being discharged with. All important quality metrics, of course.
You bet.
You can go to the next slide, please. Our outpatient clinics, or what we call our medical practice survey, that is really remarkable for me to look at these and present these results to you this year, with the exception of would recommend the facility, which is a question that's a lagging indicator. And so as we see the other questions moving in a positive direction, we will also see that, statistically speaking, we will see that question and the results of that move as well. But it does take a little bit of time for us to watch that adjustment. But if you'll look at these results, they are incredible. Every single question has had a positive movement this past year on our medical practice clinics. And I know those teams have been working tremendously hard to make sure that our patients receive an excellent experience when they come through our clinic environment. So that is achieving stretch goal at this point. If you'll move to the next slide. The other metrics that we promised to share with you this year are on this slide here, and they're not part of our annual incentive plan, but they are metrics that we look at consistently. And so you can take a look at our emergency services, including urgent care, our outpatient surgery, and our behavioral health environments as well. If you'll go to the next slide, please. I included a short-term and a long-term action planning table here. I'm really excited because tonight we are actually graduating our next cohort in from our mastery program. That brings about 160 people through that program. Special thanks to Dr. Miller, who has been my co-facilitator and co-host for the mastery program this cohort, and we're very excited with the engagement and the learning that's occurred, and we're very excited to graduate our next cohort. And again, that brings about 160 people through that program for us. The validation of our data through our new Prescani vendor and the survey that we switched to as of January 1, that you as a board approved that movement, that it has occurred for our first quarter. And that continues that will continue as we go through our second quarter's worth of data coming through our new vendor to ensure that we have full accuracy in all of our data that we present to you. And then we are doing a variety of things, as we always do, to help all of our areas in achieving just an experience that our patients have when they come here that's second to none. And those are listed out for you here. I won't go into detail on those today, but we'll bring back work plans and action plans on specific committees that are meeting and committee work that's being done, particularly on our Care Transitions Committee and our Pharmacy Process Improvement Committee that launched last month. Any questions that you have on our patient experience?
Laura, on the last slide you have is the long-term remainder of FY21.
Yes.
What is Caught You Caring? I like that.
Yeah, so that's a new program that came from our director in our patient experience department. She came from an outside organization, and they had a program that was called Caught You Caring. And so we are in the process of implementing that. And those will be moments that we see our care team doing something that's just particularly caring for our patients. So when we do observations or validations on the floors or in the clinics, it's very easy for us to find moments that our patients feel were just exceptional, or our team members feel they were exceptional. And so we will be giving them special recognition. And so that will be our Caught You Caring program that we will launch in this next quarter.
All right.
Hey, Laura, on that column also as well, when did we start doing the EMDR therapy?
We started doing that here on site as part of the Care for the Caregiver initiative. We began that 2-3 years ago. And when we had a traumatic event here at the hospital, we brought in EMDR therapists that began working with our teams and really helping to relieve some of the trauma. That we brought back as the pandemic started, and we have been offering that to our team members since last March.
Oh.
What exactly does that stand for, Laura?
Oh, I knew you were going to ask me that.
It's for desensitization and reprocessing, I think.
That's it. That's it. It's similar to what happens when you have post-traumatic PTSD, post-traumatic stress disorder. When that occurs from being in the military or any traumatic event that happens, it's a rewiring of your thought processes and the way that your electricity goes within your body. And so it rewires your brain so that you are not experiencing the trauma at those heightened levels. Mm-hmm. Our team members have found it tremendously helpful.
The long-term, it should be PTSD. It said PSTD. You may want to change that.
Oh, thank you. Thank you so much. Sorry about that.
DT, I'm going to sign you and me up for this program.
I know.
We probably need it.
We're a candidate for it.
Yeah, we are. Okay, anybody else have any comments, questions for Laura? Laura, thank you very much.
My pleasure. Thank you.
The next one is letter C, COVID-19 update. Rob. Where'd Rob go?
Thank you. I'm here. Next slide, please. So, as we've been discussing, Tarrant County experienced a profound surge of COVID-19 cases, that really started ticking up in November, and then December, January, and then sort of had resolved by the time we got into sort of mid-February. And then it's been remarkably stable since. Now there is some evidence that hospital admissions, sort of regionally may be ticking back up again, but we've been fortunately relatively stable here. We did probably get down. Next slide, please. You'll see the death curve. So that always lags a little bit to the right, as the time between disease onset and mortality from COVID can be a fairly lengthy period of time, but as you can see, that has also trailed off. Next slide, please. So here's our JPS curve. If you remember all the way back to the beginning, we had that spike from the federal prison. It was that May spike. We had the sizable July spike, which we thought was pretty tough to handle. And then we had the big spike in January and into February and March, as you can see. Next slide, please. So vaccination has gone fairly well so far across the United States and in Texas, but I think there's reason for some caution. We've so far administered at least one dose to about 11 million folks in Texas, covering almost 50% of the eligible population. Now, that's not 50% of the population because the children are not included in that. Anyone 16 and younger or under 16, which represents about 20% of our population, is not included in that. So that represents 37% of the entire population, and about 7.5 million folks have been fully vaccinated. What concerns most of us, and I think this is something we're seeing around the country, not just in Texas, is that we've largely managed to vaccinate those who were really eager to get vaccinated. And now we're into the more reluctant group. So you can see that that number is beginning to trail off as we went through April. And in a lot of parts of the country, including around here, there's plentiful vaccine and plentiful slots. So we need folks to keep showing up and getting vaccinated because we absolutely need that to get through this. Otherwise, we could see what happened in Michigan, which is a further resurgence of cases, or what some other parts of the world are seeing. The other thing that makes me concerned, of course, is that with places like India and Brazil having tremendous amounts of disease right now, and other parts of the world where we may not even really know how much COVID they're seeing because of a paucity of testing resources, with little to no vaccine in many of those locations, there's opportunity for lots of spread and the development of additional variants, which if we don't get the vaccine to everybody before we get variants that may be resistant, then we may end up in a prolonged situation with COVID. So next slide, please. So I brought you projections from UT Southwestern, or I guess I had intended to at the end of for the April meeting, which was canceled. But anyway, these are the current projections from UT Southwestern. You can see that the black curve is what we've actually experienced. So that's coming down out of our summer peak and then our big winter peak. And here's where we are, where we've been stable for a little bit there in April, as you can see. And so these different colored curves, if you look over to the right here, represent different amounts of public health measures that we may take. So blue would be if we are doing everything possible to prevent the spread of COVID. So this would be sort of lockdown level. So this is mask mandate, strong social distancing, business restrictions. Green is kind of where we were back in October and November, where we had mask mandates and business restrictions, but limited social distancing. Orange is if we go back to where we were when we thought we were out of it the first time back in June and July, where we kind of opened everything up and there was limited masking, limited social distancing, and limited social restrictions. And red is if we just went back to pre-pandemic behavior completely. So if we were to continue the current pace of vaccinations that we had at the end of April, almost no matter what happens, according to UT Southwestern, we would not see another major resurgence of disease in Texas. However, with the slowing of the vaccination that we're seeing, it does provide some opportunity for the virus to come back, even in the short to medium term. So I think that this just underscores the importance of vaccination, coupled with doing what we can to follow public health measures that are recommended by the CDC in preventing a resurgence of the disease here in our area. Next slide, please.
Wow.
So what we've done at JPS since the last time we met way back in March is we've managed to administer now over 80,000 doses of vaccine just at JPS. So we've really made a substantial contribution to the community vaccine effort here at JPS. And we've of course taken on several special populations like the jail and homeless populations. So this has been a major impact for our community. We reopened phase 2 elective surgery. In fact, March was the busiest single month for surgery at JPS. So that pent-up demand was getting addressed and is still getting addressed. We reopened the JPS Surgery Center in Arlington. We closed our COVID ICU, which had been in our admission holding unit, and that's back open again. And not knowing what's going to happen in terms of variants, in terms of vaccine uptake, and in terms of our attention to public health measures, we are remaining vigilant just in case COVID returns. So that is where we stand today in terms of COVID. Does anyone have any questions about any of that?
I haven't heard any, Rob. Thank you very much.
Thank you
for the presentation. That is all that I have for the open session. We need to we have a few things in executive session, so we'll need to reconvene in the executive session pursuant to Chapter 551 Texas Government Code for the following, which is been listed. Y'all want to press right on?
Yeah, I'd be happy to.
Dr. Weber, we will need just a minute to get close prepared.
Yeah, just let me know, Jeffrey.
All right, give us a minute. We're going to cut the feed. 2, and 1.
All righty. We're coming out of executive session, reconvene in open session for any items or action. We don't have any, and I don't have anything else for the agenda. Anybody have any comments, questions? And if not, I'll entertain a motion to adjourn.
So moved.
All righty.
Second.
Thank you, folks.
Thank you all.
Thank you.
See you at the board meeting.
Adios.
Bye.